Bismillahirrahmanirrahim. Let's discuss the topic rejection of transplant. It is basically a response mainly to MHC molecules. MHC molecules differ in the population among different people. Let's discuss the immune recognition of allograft. It involves two processes. One is called as direct pathway, other is called as indirect pathway. In a direct pathway, donor class 1 and class 2 MHC antigens are presented on antigen presenting cells in the graft, and they are recognized by the CD8 plus cytotoxic T cell and CD4 plus helper T cell respectively. What would happen that CD4 plus T cell will proliferate. When they will proliferate, they will produce the cytokines. Let's suppose we say that those cytokines are interferon gamma. Now what would happen that as a result of this, they will induce the tissue damage by a local delayed type hypersensitivity reaction. On the other side, we will see in T cells that CD8 plus cytotoxic T cells respectively, they will lead to the graft antigen differentiation into cytotoxic leukocyte that will kill the graft cell. Means that CD8 plus T cell will differentiate into cytotoxic T leukocyte and that will kill the graft cell. Let's discuss the indirect pathway. In indirect pathway, graft antigen are displaced by host antigen presenting cell and they activate the CD4 plus T cell. That CD4 plus T cell will damage the graft by local delayed type hypersensitivity reaction and will stimulate the B lymphocytes. B lymphocytes to differentiate into plasma cell. Those plasma cells will produce the antibodies that will act on the endothelium, and as a result of that, they will definitely cause endothelial injury as shown. Now after discussing the direct pathway and indirect pathway, let's discuss the mechanism of graft rejection. Both T cell and antibodies react with the graft and are involved in rejection of most solid organ allograft. In T cell mediated rejection, cytotoxic T leukocyte will cause a parenchymal and endothelial cell death, will cause DTH and local accumulation of mononuclear cells, that is lymphocyte and macrophages. As a result of that, tissue ischemia will occur, and that ischemia will contribute to graft destruction. While talking about the antibody mediated rejection, we see that there would be vascular injury through the complement system activation. Along with that, leukocyte will be activated to that site. As a result of that, there would be this thrombosis, tissue damage, dysfunction, and ischemic injury. Let's discuss the type of rejection. There are three types of rejection. One is called as hyperacute rejection, other is called as acute rejection, and the third one is chronic rejection. Hyperacute rejection occur if preformed anti-donor antibodies are present in the circulation of host before transplantation. For example, let's suppose in multiparous women who have anti-HLA antibodies against the paternal antigens encountered during pregnancy. Second, let's suppose individuals that are exposed to foreign HLA, for example during previous blood transfusion, or a patient who has already rejected an organ transplant. Now how to avoid this? Screening test can be done, and along with that cross matching can be done, and these both have decreased the rate to 0.4% of transplant recipient hyperacute rejection. When you see the morphology, you observed that the kidney that has recently shown hyperacute rejection will be cyanoted, mortared, and flaccid, and will show acute arthritis, vessel thrombosis, ischemic necrosis, acute fibrinoid necrosis. Along with that, there will be narrowing or complete occlusion of the lumen by precipitated fibrin and cellular debris. Let's discuss acute rejection. It occurs in days to weeks or may appear months or even years later. It's of two types, cellular and humoral. In acute cellular rejection that is observed in first months, the patient shows the clinical signs of renal failure. Along with that, CD4 plus CD8 plus T cell infiltration with edema, mild interstitial hemorrhage, focal tubular necrosis, and CD8 plus T cell may cause endothelitis. Renal biopsy is done, and for the treatment, patient respond properly to increase immunosuppressive therapy. While discussing acute humoral rejection, we see that it is also called as rejection vasculitis caused by anti-donor antibodies. Necrotizing vasculitis, endothelial cell necrosis, neutrophilic infiltration, deposition of antibody, complement, fibrin and thrombosis, ischemic necrosis of renal parenchyma, And to detect, we use C4D. In chronic rejection, it is caused by cytokines released by activated T cell that act on cells of vascular wall. Serum creatinine level is increased. Vascular changes, that is arteriolar with smooth muscle proliferation and extracellular matrix synthesis, interstitial fibrosis, and loss of renal parenchyma seen. That's all.